I am extremely excited today because we have Controversies, which I think is always one of the most interesting and fun grand rounds. And I think we all learn a lot from it. And today we are very lucky to have Dr. Stephanie Rutledge as our presenter. Stephanie graduated from the University College of Dublin and went on to do her internship and senior house officer training in Ireland before she moved to Boston for internal medicine training, where I had the privilege of being her co-resident at Mass General Hospital. She moved to New York to pursue GI fellowship here, and she plans to do transplant hepatology fellowship here following her GI training. She's interested in alcohol-associated liver disease, and outside of work, she enjoys spinning, traveling, and trying all the restaurants New York has to offer, even in the COVID setting. I assume that means very safe outdoor dining or take-in only. She is going to give us a really exciting talk on eosinophilic esophagitis today. Because Controversies is best when you can actually see all of the panelists, I'm going to try a Zoom feature that I learned yesterday called the Spotlight View, but I also recommend that you guys hide any non-video participants and that only the panel stays on video. And that way the default is to see all of the video participants so that we can really focus on Steph and all of her guests. So without further ado, take it away, Dr. Rutledge.
Great. Thank you, Dr. Gottlieb, for the lovely introduction. Can you see just my slides?
We can see your slides.
Perfect. So very excited to be presenting to you today on a topic which is very important to me. That's eosinophilic esophagitis, and we'll be hopefully generating some controversy around its management. Sadly, I have absolutely no financial disclosures to declare. I do have one admission of guilt, which is that my future husband, we're due to get married next week, does have eosinophilic esophagitis, which I sadly missed for 4 years while he vomited up his food in the bathroom. So today we have a stellar group of panelists, including Dr. Myrna Chahadi, who's the Associate Professor of Pediatrics, Allergy, Immunology, Medicine, and GI here at Mount Sinai Icahn School of Medicine. We have Dr. Lawrence Cohen, who's Professor of Medicine and GI at Mount Sinai. Dr. Michael Dugan, who's Assistant Professor of Medicine and GI at Harvard Medical School and Mass General Hospital. And finally, we have Dr. Alexandros Polidourides, who's Professor of the Department of Pathology, Molecular and Cell-Based Medicine, as well as Medicine and GI here at Mount Sinai Hospital. So thank you to all of you for agreeing to just take part in our controversies today. What are our objectives for the talk? So we're going to learn how to make the diagnosis of EoE and talk a little bit about what are the first line treatment options for EoE. Where do PPIs come in? And what about elimination diets? And finally, to borrow a term from the IBD literature, should we be treating to target? And what is that target that we are trying to aim for? So starting with the diagnosis. EoE is a chronic immune or antigen-mediated clinical disorder of the esophagus and is characterized by both esophageal dysfunction, so symptoms of dysphagia, as well as inflammation, which is characterized by higher numbers of eosinophils. Initial reports in the 1990s described these multiple esophageal rings on endoscopy back in the time of Jerry Way, but there was no response to antacid, so it was thought that perhaps these were congenital. But we have seen an increase in the incidence and prevalence of the disorder, which is partially due to increased recognition, but not fully accounted for by the recognition. And we believe this because if you look back at the barium radiography that has been practiced for decades, we think that the characteristic ringed appearance of the esophagus on barium swallow would have been described years before. The prevalence is about 0.5 per 1,000. 70% of patients are male, typically Caucasian and under the age of 50. And along the lines of the hygiene hypothesis, whereby lack of exposure to good old germs causes autoimmunity, we see in EoE that lack of early microbial exposure, premature birth, and lack of breastfeeding all increase the risk. And although we see some correlation in twin studies, the majority of the risk really comes from the environment at over 80%. The symptoms of EoE, dysphagia is above and beyond the most common, and often patients have had this for years and they've adapted by either chewing slowly, avoiding certain foods, liquefying their foods, so they may not even realize that they have a symptom. So it's important to really delve into this when you see patients in the clinic. And dysphagia does not necessarily mean that they have a stricture. Dysphagia can be from mucosal stickiness due to the eosinophils, or it can be from fibrosis or stricture. We find EoE in about 15% of the endoscopies that we do for dysphagia. And Satish asked me a good question recently. how many of the dreaded food impactions that we're doing overnight, he didn't put it exactly that way, but how many of the food impactions that we're doing end up being due to EoE? And a few retrospective studies have looked at this, and they found that just under 1/5 of EGDs for food bolus impaction were ultimately due to EoE. But when they look at the patients who were biopsied, half of them were found to have EoE. So this is a reminder, I think, to all of us that even when it's 2 a.m. and you're in the OR, it's important to try find a jar of formalin to grab a few pieces of esophagus and put inside, because when that patient leaves, they may not be coming back to GI until the following Thanksgiving when they impact that dry piece of turkey again. So in terms of atopy, it's very prevalent in EoE. Most patients have some form of allergic disorder. Even in adults, it's up to 90%. The most common is allergic rhinitis, followed by asthma. And in terms of presentation, we see that with increasing age, dysphagia is a more common symptom. And so children are more likely to present with feeding difficulties, whereas adults much more likely to have dysphagia, less likely food impaction, less likely heartburn. And so these are the updated diagnostic criteria for EoE, which came out in 2018. And they describe that in the right clinical scenario, such as a young man with dysphagia and underlying hay fever, asthma, you should do an EGD with biopsies, even if the esophagus looks normal. And if you have more than 15 EOs per high power field in any part of the esophagus, you can make a diagnosis. However, and this is the harder part, you must exclude any non-EoE disorders that could be contributing to the esophageal eosinophilia. And they include GERD being the most common, Crohn's, esophagitis, parasite infection, and so on. And you'll note the lack of response to PPI is not one of the requirements for diagnosis. And this is controversial, so that's why we'll be returning to this point later on in the talk. Here are some of the most common endoscopic findings. We see, as shown in the photos, that furrows are the most common finding, present in nearly half. You see these rings that you would see in a cat's esophagus, hence the term feline esophagus, in 44%. And then these are the white papules, which are microabscesses teeming with eosinophils that are found in 27%. But probably the most important thing to remember is that normal esophageal mucosa can be found in 10% of patients with EoE. And that's why we should always be biopsying, which I think we do a pretty good job at in the outpatient setting. I think with increasing physician recognition, that number of normal, that percentage of normal mucosa has decreased as we have become more and more aware of the prevalence of EoE. So less now physicians are reporting normal mucosa because they're more likely to pick up the subtle findings. And so what to take home from the diagnosis of EoE? We know that it's a patchy disease like celiac. So take at least 2, if not 4 biopsies from the distal and mid or proximal esophagus. We have some pretty good data showing that the probability of finding the diagnosis increases with the number of biopsies that you take. However, you really maximize your yield when you come to about 4 biopsies total. And there is some correlation between symptoms and histology, but like in IBD, it's not perfect. Patients with fibrosis and strictures may be much more symptomatic than those who are merely inflamed. And I think it's really important to remember that even with increasing recognition, that there can be other causes of eosinophils in the esophagus, so not to jump to the diagnosis of EoE. And so now I'm going to turn to the panel, and I would love to have some of your opinions, perhaps starting with Dr. Cohen. Do you put more weight into the distal or the proximal esophagus? If your biopsies return and the proximal has EOs and the distal doesn't, or vice versa, which is more important to you? And how do you treat the patient? How do you give the patient that diagnosis if the EOs do not correlate proximally and distally?
Thank you. Well, first of all, I think it's important to recognize that when we talk about distal esophageal biopsy, that we should not be taking it from the lowest 2 to 3 centimeters of esophagus, because you can see significant eosinophilia from reflux, even in relatively asymptomatic patients with GERD. So the biopsies should be in the lower third of the esophagus, but not in the most distal several centimeters. In terms of looking at differential numbers of EOs in the distal and proximal, I look at, obviously you look at both. You look at the gradient, the difference between the number that you have, the absolute number you have in the proximal and distal. But I wouldn't ignore the finding, though, when the patient has more than 15 EOs either distally or proximally, you have to have an index of suspicion that this may be EoE.
Great. Thanks, Dr. Cohen. That's very helpful. So I guess, when you have a number like 15, does that to you, is that significant, or are you looking for an even higher number than that to really convince you that this is EoE?
Right. Well, I think it depends on, first of all, whether the patient's been treated or untreated. Often now patients come in, they've been on PPIs. So I think you have to take that into consideration. But in an untreated patient, we'll consider any number 15 or above as being suspect. And as you pointed out, and we'll talk about further, you then have to exclude other causes of eosinophilic infiltrate in the esophagus. And I would just add to your list of causes eosinophilic gastroenteritis, which should be considered in anyone that has increased eosinophilic infiltration in the esophagus.
Perfect. So I think, Dr. Cohen, you had mentioned to me before, some experts do recommend that at the time of the EGD, you do a biopsy of the stomach and duodenum to exclude a coexisting eosinophilic gastroenteritis. Although I think it's still even rarer than EoE.
Yeah, I think that if you suspect EoE strongly, I think it's wise to grab a couple biopsies in the stomach and duodenum just to rule out coexisting involvement of the stomach and duodenum.
Great, thanks, Dr. Cohen. So moving to Dr. Chehade, I have a question for you. If you're doing an endoscopy and maybe the patient is not the right phenotype for EoE, so it's an older Hispanic woman who's obese and has a large hiatal hernia on her endoscopy, and she's not on a PPI, and the path comes back with even say 50 EOs. Are you telling that patient that she potentially has a diagnosis of EoE, or given that the clinical phenotype doesn't really fit, are you treating her as heartburn and doing something a little bit differently than you would usually?
Well, first, thank you, Stephanie, for inviting me on this panel. It's a pleasure to be with you. These are good points. First, I'd like to clarify that, when you mentioned it's not the typical person, I would not add here a Hispanic overweight woman as less likely to have EoE, because we've noticed that these patients are actually the ones that end up to be missed because they're more likely to present with a non-typical presentation. So they're less likely to have dysphagia. They're more likely to have persistent heartburn, for example, or substernal chest pain. And we do have so far preliminary evidence that racial minorities are actually underrepresented in this or underreported in this disease. So the second part to this answer is, if you having now a hiatal hernia in any patient, a hiatal hernia, maybe you're seeing some erosions or ulcers, and this patient was not on PPI and has 50 eosinophils, it doesn't mean automatically that there's EoE. So it could be all GERD or acid-induced reflux. It could be EoE and reflux. So you may not necessarily want to start immediately with a therapy that is so targeted to EoE, and you might want to start with a PPI in that situation and see and tease it out to see, is there a concurrent EoE there, or is it all acid reflux? Because just like what Larry mentioned, high eosinophils doesn't always mean EoE. There's a whole differential there.
Okay. And so maybe coming back, you might put them on a PPI, come back to their endoscopy a couple of months later and have another look?
Yes, and see what happens with their symptoms as well. But yes, I would take another look because of the high number of eosinophils that you've seen compared to those with reflux, who, if they feel better, you may not scope them again.
Okay, great. Thank you. That was very helpful. And then Dr. Polydoroides, I had a couple of questions about the pathology. When we're sending up biopsies for EoE and we're concerned with on the clinical requisition, it says dysphagia, are you automatically reporting eosinophils? And what is the cutoff that your lab is using as sort of a standard to maybe increase the likelihood that this is the diagnosis of EoE?
First of all, thank you for having me on this panel. And I'd like to, before I answer that question, I wanted to go back to what Dr. Cohen said, which was the number 15 for him is just something that increases the suspicion. And that's exactly the best way to put it. Even though, studies initially had actually used 20 as a cutoff and then lowered it to 15, that is meant to be as an indication to look into it. That number is not something that is hard and fast, that if it's 15 and above, it's definitely EoE. And if it's not, if it's below, it's not. And in terms of that, even though 15 sounds like such an objective criterion that you would think would be the same across the board, there are some parameters that make it a little bit less objective than you would think. And first and foremost is the concept of the high power field. Everybody talks about high power field. Not every high power field is the same. That depends on the microscope. So some microscopes might have a wider high power field than others. So depending on what studies were initially done that brought up the cutoff of 15 or 20 and what kind of microscope they used, that high power field might be different from, say, my microscope, which is, I know, 0.25 micrometer square, but it could be bigger, and therefore you would get more of them. There are also some other parameters that, that require some thought in terms of, not all pathologies require every cell every cell as an eosinophil. There's some controversy among pathologists in terms of whether you count a cell if you see the nucleus as well as the granules, or just the granules, or can you take part of the mucosa if it's folded? Would you count both sets in that high power field? There's some controversy in terms of that number, which basically just means that that number is just a starting point, and that you should use it as increasing your suspicion clinically to then look into it. And in terms of the same number, when you start talking about treatment and lowering that number, going from, say, from 20 to 15, I wouldn't necessarily use that as direct evidence that treatment is working, for example, right? Unless you see big differences because of all these sort of variables that I've mentioned. In terms of what we do in the lab, if it's above 15, because that number is actually quoted in the literature and we use it, we would mention no matter what. No matter what the indication is, no matter what the requisition form says, if there's an esophageal biopsy with more than 15 eosinophils, we'll actually mention it and give the number. At least I think most of my colleagues would do that, and I think most GI pathologists in the country would do that as well. If it's below 15, it would sort of depend on the setting a little bit. So if it looks like it's reflux and there is G-junction biopsies to rule out Barrett's, and there is H. pylori in the stomach, and maybe there's like 5 eosinophils in the G-junction, I might completely ignore it. So I would definitely mention it if it's above 15. And then if the requisition specifically says that this is an EoE patient being treated, for example, or being evaluated for EoE, then I would give the number regardless of what it is in order to give you an idea. So if it's treated and they've gone below 15 and they've gone down to 8 or down to 2, I would give you that number as well.
Great. Thank you, Dr. Polydoroides. That's very helpful. I think it sort of reinforces that it's not as simple as just 15 being the magic cutoff, that we need to look at the clinical case, what else we see on endoscopy. And
so Stephanie, I guess that that emphasizes what Dr. Polydoroides and Dr. Cohen mentioned, is that, you have to look not just at the histology. So you have symptoms, endoscopic findings, and histology that you have to take into consideration when you're suspecting EoE or not.
I think that's a really good summary. I completely agree. And that actually brings us nicely on to our next case, which is a case that I'm personally invested in. It's the case of a 30-year-old Irish male who moved to New York very recently. He has mild asthma and allergic rhinitis, and for years has been struggling to swallow solid food and has been self-inducing vomiting in bathrooms. He had an EGD done in Ireland back in 2014, which was normal, but there were no biopsies done. And his adoring fiance attributed these strange symptoms to globus and stress. And somehow we are still getting married next week. So he moved to the US, where he had dinner with an observant cardiology attending, who had the wherewithal to notice that the patient was spending most of the night in the bathroom regurgitating up chunks of his filet mignon. He advised him to see a real GI doctor, not just his significant other, who did an EGD. And now the EGD shows longitudinal furrows, mucosal friability, and esophageal rings. The pathology was notable for 20 EOs in the distal esophagus and over 40 in the proximal, which I'm not sure that our lab has an upper limit that they stopped counting at, but maybe we can discuss this in a few minutes. At this point, he was told that he had EoE and started on omeprazole. And within a few weeks, all of his symptoms had resolved. And here you see us at a chocolate factory where the patient has no trouble swallowing, which in my mind is really the treatment goal that we should be aiming for all of our patients. And so moving on to the next learning objectives, where do PPIs come in the treatment diagnosis of EoE? And so the PPI story is an interesting one. In the beginning, we were advised to treat patients with a PPI to rule out GERD. But then this landmark study came out in 2011, and it showed that 3/4 of patients with eosinophilic infiltration responded to a PPI. And you'll notice that this is a pathological diagnosis of eosinophilic infiltration in the tissue. And therefore that cohort included some patients who had GERD and not EoE. So when they looked at the patients with the more typical EoE phenotypes, such as allergy, dysphagia, and characteristic endoscopy findings, they saw a 50% clinical and pathological response rate, which is closer to what the other more recent studies have shown. There's a very complex relationship between GERD and EoE, and especially with GERD on the rise due to obesity, the two disorders frequently coexist. We know that GERD may cause eosinophilic infiltration due to reflux injury, and it can actually cause breakdown of the esophageal mucosa, which allows allergens and antigens to be exposed to the immune system. And we think that it may predispose to EoE in that way, although a lot of this still needs to be fully elucidated. On the converse, we know that EoE-induced fibrosis and dysmotility can itself cause GERD over time. So over the past decade, we have really started to understand that PPIs are doing a lot more than just reducing the acid, but they're causing reversal of the type 2 immune response in the esophagus through normalization of mast cell genes and decreased eotaxin expression. And that's very similar to the effect that we see of topical corticosteroids on EoE. And here in the graph below, you see the expression of the mast cell gene tryptase in EoE, PPI-responsive EoE, which is a term that we don't use anymore, but you can see that they're very similar. And then in PPI-responsive EoE, after treatments with EoE, the tryptase expression is much, much lower. And again, here you see staining of tryptase prior to PPI and post-PPI in EoE. So we now know that patients who were labeled as this subgroup of PPI-responsive EoE are far more similar to EoE patients than GERD patients, and that their transcriptome and genome signatures are nearly identical. And this reinforces the idea that esophageal eosinophilia, independent of PPI response, shares a genetic etiology. And we know that patients' acid on pH monitoring does not predict their response to PPI and EoE. They can have normal acid and still respond to a PPI. A meta-analysis of over 600 studies showed that PPIs were associated with histologic remission in just over half and symptomatic improvement in 61%. So pretty good outcomes from PPI. And just to really summarize how we've seen the evolution of thought process when it comes to PPIs over time, we initially used the PPI as a diagnostic tool to rule out EoE, because if they responded, they were diagnosed with GERD. Then we saw that the PPI was perhaps a diagnostic tool to differentiate between EoE and the PPI responsive EoE. And then this term went to the wayside when we saw how similar PPI responsive EoE was to EoE, that they're really one and the same. And so now we do not use the response to PPI to exclude EoE, but in fact, it's one of its first line therapies for treatment. And so now I'm going to stop and ask a couple of questions of the panel again. Maybe starting back with, say, Dr. Cohen. So you have a 30-year-old man in the clinic. He has asthma and allergies, but he has straightforward GERD and no dysphagia. The guidelines would suggest that you put him on a PPI and check his response. But given what you know about EoE and its increasing prevalence, is this someone that you would consider doing an EGD and endoscopy on first so as not to miss EoE? Or is there something specific that you'd be looking for in the clinical history that would really push you to scope this patient?
Yeah. Well, that's a great question. I think we don't scope the vast majority of these patients, Stephanie, because we see hundreds of patients that are in their 20s, 30s, have fairly classic symptoms of reflux. Obviously, a certain percentage of them will have allergic or asthma-related symptoms just based upon probability. So we don't scope most of these patients. My sort of acid test for this is whether or not they have difficulty swallowing. If they have dysphagia, then they warrant an endoscopy, and that would be true if in anyone with GERD. We've been taught since medical school that that if patients have a so-called one or more warning signs of reflux, that they need to be evaluated, and certainly dysphagia, food impaction, and so on is among the warning signs. So I use dysphagia as the discriminator for deciding whether to scope someone who's young, who fits some of the demographic criteria, and has classic reflux, provided that they respond. It's provided that they respond to PPIs. Obviously, the corollary is that if you have a patient who's 30 who has burning in the chest that is unresponsive to PPI, that also will be an indication to scope them.
Right. So if they have dysphagia and respond, would you scope them before putting them on a PPI in case you then normalize the mucosa and miss the diagnosis?
Yeah, I think ideally, if you're planning to scope them, if it's in your algorithm for evaluation from the outset, you're probably better off waiting until you scope them.
Okay, thank you. And Dr. Chahade, I know you see a younger cohort than we do. Same question for you. Young child coming in, how are you sort of thinking about if they're describing, say, I'm not sure how well children can describe this, but some burning or some of the symptoms that you see in your clinic, do you have any way of distinguishing EoE from GERD, which is much more common in adults, but we can't get the transcriptome analysis on the patients that we see? Is there any red flag that's sort of stands out for you when you have a patient in the clinic? What has been to you the most predictive factor of having EoE?
Well, first, I agree with Larry. I wouldn't scope everyone who's having heartburn, even if you have history of severe asthma, because if you just look at the statistics, if you have a patient with dysphagia and or food impactions, the likelihood of having EoE is much higher than somebody who has reflux. So we have to still keep in mind the prevalence is 0.5 per thousand of EoE. So, and a lot of patients reflux. So in a patient who's refractory to PPI, even if they just have heartburn, don't have dysphagia, I would agree with Larry. I would scope that patient as opposed to moving on to a higher dose of PPI or adding another treatment the way you have it currently in the GERD guidelines for adults. So I might just scope right there in a refractory patient. If there's dysphagia on food impaction and you're seeing them in an outpatient comfortable setting, then it would be good to have that endoscopy before starting PPI. So you're not going to miss a PPI responsive patient who will disappear. Now in children, it's really more difficult than in adults. The adults, I consider them the easy ones because they will, one, they can tell you what they're feeling, unless, they have behavioral feeding modifications to reduce the severity of dysphagia or to prevent food infections. But again, with few extra questions, you can get that. How are they eating in general? But with children, their presentation can be altogether different. So they could have very non-specific symptoms like abdominal pain, intermittent vomiting, and reflux symptoms. The probability of dysphagia is much lower, as you showed in that graph. So what happened with these, that's almost the entire pediatric population that comes to a GI doc besides constipation, etc. And so with that, certain red flags would be if you're having a patient who's not growing well. So failure to thrive is a big one. A child who's refluxing and has a plain reflux does not give you failure to thrive. So if you see failure to thrive, that's an indication. And also you're looking for features of atopy. So atopic comorbidities like asthma, allergic rhinitis, atopic dermatitis, but also you're looking for history of atopy in infancy or something that suggests that. For example, blood in the stool when they were infants on plain cow's milk formula, or frequent vomiting, and then they outgrow it. Typically, they outgrow it by 1 year of age, and those are the patients at 5-6 years of age where you start seeing EoE in those patients when they outgrow their initial GI problem. So you would look for these, and those would be red flags in that case to start thinking EoE in those patients.
Great, thank you. That was also very helpful, sort of giving us a picture of the children and the adults in the various presentations. A quick question for Dr. Prilly-Duroides. I was curious to see that there was in Mass General where the patient had his first endoscopy, they reported greater than 40 EOs. I had thought here that we really quantified them to a higher number. Do you use a typical cutoff where you stop counting?
Yeah, there are no guidelines for that, so it's more like a personal preference. I think most pathologists here would make an effort to basically count as much as possible. Obviously, once you reach 100, it probably becomes like a moot point. So I think, when they say more than 100, it could mean 105, but it could also mean 200. It's just way too many to count after a point.
Right.
But I think here, when we say, up to 40, it means that we checked a couple of high power fields and we went to 39, 40, and if we say more than 50, I think we mean in the vicinity of 50 to 55, So when we say more than 50, we don't mean 200, we mean around that area. But again, I would preface this by saying it's a personal sort of preference. There are no guidelines, so some pathologists could stop counting at 40 because they think it doesn't matter above that. So, you know, it would be interesting to see, you know, as more studies is being done on that, on whether, you know, the degree of eosinophilia makes a difference. In other words, you know, if you have like 400 versus 25, whether your disease is much worse or whether you respond to some treatments versus others. I don't think that's been done to a large extent.
I don't think so either. We will talk a little bit more about the numbers in a little bit. So I'm going to bring us back to our case.
Well, it helps us sometimes, though, Stephanie and Alexi, sometimes it helps us to know if somebody has 100 went down to 50, for example, if there's some partial treatment, along with when we look at the endoscopy and symptoms. But first, I really want to say kudos to our GI pathology department, Alexi, Dr. Harpaz, and the entire team there. They, with counting every single cell and reporting on many other features that we all look at in addition to just eosinophil count. So as you mentioned, Stephanie, there's not just eosinophils that are high in EoE. You mentioned mast cells, but that's just part of the story. They also look at basal zone hyperplasia. They look at degranulation of the eosinophils. So let's say now you have 15 eosinophils, but there's tons of degranulation. They're seeing lots of eosinophil granules on that tissue. That number could have been, if those eosinophils are intact, much higher. So they report on all of these features that are very important in like determining when there's a response and you're not sure whether you should keep that treatment and add something or switch altogether. So those numbers then become really important in terms of management as opposed to predicting, in terms of as opposed to prognostication.
Yeah, which brings me actually to an important point. It's very helpful to us. In fact, it's probably crucial if we're told that a patient is being treated for EoE, because for one reason, because as Mirna said, we will be a little bit more careful in terms of what we say. Our numbers will be more exact. So we wouldn't just say, you know, very cavalierly, you know, more than 20. We would give you a little bit more of an exact number, because if it was 50 before and now it's 20, that's an order of magnitude almost. So it's probably, you know, it's beyond these sort of variables that I mentioned earlier that could affect the measurement. But if the patient is being treated, particularly if they're being treated with steroids, it's very important for us to know, because we will look very, very carefully for things like candida, which happens very commonly and it's very easy to miss. Especially, you know, these patients are immunosuppressed from the steroids that they swallow. They have no reaction at all, and you can have, you know, a couple of little candida organisms in the corner that you can easily miss. So it's very important for us to know if the patient is being treated.
That's really important now. I think helpful for all the clinicians to know that we should be mentioning that when we are doing these biopsies. So these are the new AGA guidelines for EoE, showing that your first-line therapy can be medical, PPI or topical corticosteroids, or dietary therapy. All of those are considered equal. If at any point the patient develops a clinically significant stricture, you can do a dilatation. And we now know that perforation is not more common in patients with EoE undergoing stricture dilation than any other patient with strictures. It's about 0.3% rate of perforation. Once the patient develops a response, they should really go on some sort of maintenance therapy. And if not responding to one, such as medical therapy, you can switch to dietary or vice versa. But if you have tried all of these things, PPI, steroids, and diet, and there's no response, you may want to consider the patient as a non-responder. And other options include immunomodulators like azathioprine, which the data are not great for. There are multiple clinical trials going on at Mount Sinai, which Dr. Chahadi will tell us about towards the end of the talk. And you can consider combination treatment or leukotriene antagonists, which don't have great data either, but something to consider in your non-responsive patient. And so what about diet? Back in the 1990s, we had a landmark paper which showed in children that an elemental diet, which has no proteins, no antigens, just amino acids, it's essentially tube feeds, was effective in inducing remission in over 90%. And most of EoE is allergen driven. This really proves it, and it represents a nice drug-free approach. We see in adults that nearly 95% will go into histologic remission on an elemental diet. But when you look at the intention to treat, on a 4-week trial, just over half of the adults were able to continue the diet. And so while it works, it is pretty miserable and not a great way to be living your life. Also, the children in the first study all needed NG tube feeding in order to do the diet. So the tube feeds are really not very palatable, as you can imagine. In 2006, they came out with the 6 food group elimination, which was over 70% effective, eliminating the 6 most common food groups shown here. and it was easier to do than elemental. People later proposed that perhaps skin prick or atopy patch testing would give us the specific food allergens that the patient should be avoiding. But unfortunately, study after study has shown that these are an ineffective way to predict who will respond to certain elimination diets. There's only a concordance of about 13%. And so this is the 6 food elimination diet. Here you see the 6 food groups listed in descending order of frequency of being the trigger. And all 6 food groups are removed. And then the patient has an EGD done 6 weeks later. And if in remission, 1 food group can be brought back, and so on and so forth until they have recurrence of disease. And then you know that this food that you just introduced was the trigger and needs to be removed lifelong. However, after all these endoscopies and dietary trials, we see that 3/4 of responders to the 6 food diet ultimately were found to just have 1 or 2 food triggers. And this is why the 2-4-6 step-up diet was created in 2018 by a Spanish group, which showed that if you eliminate the 2 most common triggers, dairy and wheat, and do an EGD, and then can step up to 4 and then 6, if not in remission, that you can identify your responders to 1 or 2 food triggers much earlier on, such as at the 2 or the 4 food diet stage, without subjecting the patient to a 6 food elimination. Their studies show that you can save 20% in number of procedures done and about 30% in the time to make a diagnosis of which allergens are the culprits. Here are the overall response rates, with approximately 40% responding to 2 food, 60% to 4 and 2 food combined, and 80% to 2, 4, and 6 food. So you can remember this as the 40-60-80 rule. Very important to remember, though, that this was a per protocol analysis and not intention to treat. So this is the number of people who responded as a function of all the motivated people who stuck with the diet. 28% dropped out from the get-go. And over the course of the study, 127 out of the 227 patients said at some point that they no longer wanted to do the diet. So these are the response rates, but in the people who are motivated to do this diet. And just to summarize then what we know so far about the dietary therapies, milk is by far the most common trigger in 81. It's one of the triggers in 81%, but in only 18% of adults is it the sole trigger. So in just under a fifth, there is milk-induced EoE, where eliminating dairy will cure their EoE, more common in children though. We know that over 90% of responders to the 2 or the 4 food diets are ultimately found to just have 1 or 2 triggers. So this argues for more of a step-up approach to try and identify those patients early who never will need a 6 food elimination. And it's important to remember the cost of all this. Dairy and gluten are in a lot of the foods that we eat, so buying foods without them is expensive. And a study showed that there was an increased cost on the weekly shop of just over 17% when doing a 6 food elimination diet. And so here we see in a graph, just summarizing what we know, 90% respond to elemental, 80, 60, 40 to the 6, 4, and 2 food elimination diets respectively. If you do allergy testing, maybe you can get about a 30% response, which is better than some of the original studies suggested. And so I'm going to stop here and ask a couple of questions for the panel. So Dr. Chehade, I would love to know, when you're seeing a patient in clinic, how are you deciding who you're going to put on a diet? And are there predictors that signal to you that this is a patient who's going to respond, either something in their clinical phenotype or maybe something from a psychological or psychosocial standpoint that's telling you that they're going to be able to comply with it in the first place?
So good question, Stephanie. What I do is I have a long discussion. So when I'm seeing the patient for the first time and we're deciding on a treatment, so this is the longest discussion usually in the office where I put out medication on one hand and a diet on the other hand. So and so if they say, well, tell me about the diet, and so we discuss all of them. So in terms of diet, and if they're not sure if they want a diet, we look at age. We look at how restricted or how self-restricted their diet is. EoE patients, including adults, can be very picky because they develop that problem over time. And some of them just picky to start with. And many of them also have food allergies. So their diet's self-restricted. So you have to take that into consideration if you have to remove more foods. The third thing, which is really important, is their social and financial factors. So are they motivated to do the diet? If patient's not motivated, don't even try it, because you just showed us how difficult it is. The second thing is, do they have the financial and the social support? Because when they go through a diet, they can't go at it alone. Their family has to be invested, their workplace has to be invested. In case of a child, their school has to be accommodating all of this. And finally, if they go on a diet and they remove multiple foods, are they willing to go through that multiple endoscopy regimen afterwards to really figure out what's the minimum number of foods to be avoided? So those will make us decide together whether a diet is the right thing for them or not. And if it's, and then you have the medication on the other hand, which we discuss, including PPI, topical corticosteroids, and biologic, and give them the preference in that order: PPI, then potentially topical corticosteroids, and lastly the biologics, just because now biologics are in clinical trial phase, so we don't know where they eventually will fall in this regimen.
Great, thank you. I think that's important to remember, to sort of look at the logistical factors of doing a diet. We're going to move on in a minute in the interest of time. I just have one question for Dr. Cohen, which is, what diet are you starting with, given now that there's the 6-food, the elemental, which I don't think anyone's really doing, or the 2-4-6 step up? What are you telling your patients? What are you starting with?
Right. I now start among those that opt for dietotherapy. I start with a 2-food elimination. If you go back 10 years or so, where we were looking at very rudimentary types of diets that were elemental or 6-food elimination, I essentially had not a single patient in my practice that had opted for dietotherapy. As we've now learned that a significant fraction will respond to less than 6-food elimination, I've had more uptake among patients. So I agree with Myrna completely. It really is a discussion. In some ways, it's very simplistic. Patients can be divided into medication takers and non-medication takers. There are people who are adamant they don't want to be on medication regardless of what the indication is, and they're a much easier sell for diet. And then there are those people who really don't want to inconvenience themselves, and where medication clearly becomes the choice. But to answer your question, I start with the 2-food elimination.
Great, thank you. I think it's so important to remember the case at hand and the individual patient. So that's why we're going to come back to our case in just a second. Our final part of the talk is about, should we be treating to target, and what is that target? But let's go back to our patient, Dave, who tried an elimination diet, which involves removing gluten and dairy. And unfortunately, this is much harder than it sounds. And he wants to tell you a little bit about how that went for him.
Thanks. Yeah, and look, no hard feelings for the years of misdiagnosis and possibly neglect. I think for me, from the patient perspective, the dietary approach was surprising in how much education I needed to do on it. I was surprised and honestly disappointed in the amount of dairy in my chips or crisps for the Europeans out there, and gluten in my soy sauce that I would typically have in my sushi. Also, going out to dinner with friends and loved ones, it was you're constantly that person at the table bugging the serving staff, asking questions about the menu, can they adjust certain items? So it becomes a little frustrating over time.
Great, thanks, Dave. And so he remains on his PPI, as you heard, and he does the elimination diet where he's asymptomatic but severely socially impaired. And his repeat EGD shows no real improvement in the overall number of eosinophils. So what do we do with him next? And what is our treatment endpoint? How far do we push it? Because if he's asymptomatic, what is the long-term risk to him? Well, we know that the eosinophils and inflammatory cytokines cause remodeling, which results in fibrosis, stenosis, dysmotility, and rarely esophageal perforation, usually from patients inducing self-vomiting after eating to bring up their food, which when it's starting to become impacted, which is what our patient was doing. And probably due to a lack of awareness and the presumptive diagnosis of GERD, there's quite a long delay in the diagnosis of EoE at about 4 to 6 years. It's shorter in the younger and the older age groups, probably because in the elderly, there's concern for esophageal cancer, and in the younger age groups, their parents are concerned when they're not gaining weight. We also know that if a patient has food allergy or atopic dermatitis, that there's a shorter time to diagnosis, perhaps because of the higher awareness of EoE coexisting with these conditions. And then what about the number? Like we sort of discussed earlier, there isn't really a single number, but some small studies have shown that targeting an EoE count, an EO count, maybe even as low as a 5, can better predict the clinical response than the traditional 15. But to me, the million-dollar question is, what is our eosinophil target to prevent fibrosis and long-term complications? I don't think we know this quite yet, but finding this out will ultimately guide how we are treating our patients and what target we're going for. So the data on whether untreated inflammation results in strictures is mostly from this large Swiss study where they have a huge registry of EoE patients. And we see that with increasing delay from symptoms to diagnosis, patients were more likely to have a stricture, increasing from 17% at 0 to 2 years with a delay to diagnosis, and 71% when the delay is greater than 20 years, so 20 years of untreated symptoms. This diagnostic delay is really the only proxy we have for untreated inflammation because we don't have randomized controlled trials of treating or not treating. And we know that in Crohn's disease, the inflammation can burn out and patients can have fibrotic strictures with no inflammation. But you'll see in eosinophilic esophagitis that this is rarely the case. Even in the patients with 20 years of undiagnosed EoE, they still have the darkest black here, which is inflammation and fibrosis. So they rarely burn out and develop fibrosis alone. They continue to have concurrent inflammation. We know that there is no correlation between the absolute number of eosinophils and fibrosis. So it doesn't seem to be directly related to the severity of inflammation at that one time point, but rather long-standing untreated inflammation. And so can we change the natural history and reduce the risk of fibrosis? Some of the short-term studies have shown that diet and steroids can reduce esophageal tissue fibrosis and remodeling. And patients on these therapies are less likely to have food bolus impactions. So it seems logical to surmise that treatment does reduce the risk. What about corticosteroids? So at this point in time, there are no FDA-approved corticosteroids for the treatment of EoE in the US. In Europe, the European Medicines Association has just approved Orodispersible budesonide because a randomized controlled trial showed 58% complete clinical and histologic remission at 6 weeks compared to 0% at placebo. And this fits with the previous randomized controlled trials that show 65% histologic remission on swallowed topical corticosteroids. And so at this moment, we are advising patients who go on steroids to either spray a fluticasone inhaler in the back of their mouth and then swallow it, or open a budesonide capsule, mix it with something like Splenda to make a viscous slurry. Although theoretically the slurry moves through the esophagus more slowly and has better contact time, it is expensive and it requires the pharmacy to compound it or the patient to self-mix, which is fraught with difficulties. And the more recent studies have shown no difference between the fluticasone inhaler or the budesonide slurry at induction dosing. So we do need to remember to advise patients to refrain from eating or drinking for 30 to 60 minutes after they take the steroids. It is quite amazing that a spray of an inhaler that's then swallowed or a slurry of steroid that rushes past the esophagus does result in such an incredible response of EoE. So we do think that the esophageal mucosa is exquisitely sensitive to steroids, but dwell time is important. And the longer contact the steroid spends with the esophageal mucosa, the higher the response rate. And newer formulations are being developed, such as mucoadherent budesonide, which moves through the esophagus very slowly. And some initial trials have shown that that has a 95% histologic remission. So we know that EoE will recur off treatment, and the predictors of remission, of staying in remission and not recurring, are being female, younger, having a lower BMI, and no esophageal narrowing. But can we stop steroids and they will stay in remission? This is the study which really showed that we cannot. 350 patients were treated with topical corticosteroids in that Swiss registry study. They had a very long median follow-up of 6 years, which for EoE is a long time. They found that only 9% or 33 of their patients went into a deep remission, but their criteria for deep remission were very stringent. They needed to have no symptoms, no endoscopic or histologic findings for at least 6 months. And then they stopped their steroids after they were in remission, and 82% of them relapsed off treatment with a very short time to relapse of a median of 22.4 weeks. So what were the predictive factors of who was going to relapse or not relapse? Well, the non-relapsers had a slightly shorter diagnostic delay, so maybe their disease was less advanced, and trended towards being those who were quicker to respond to treatment. So those who got into remission faster were more likely to stay in remission. And what about the side effects, which were discussed a little bit earlier? People were concerned that there would be rates of dysplasia, but due to steroids, like we might see in skin cancers or mucosal atrophy. But this was not something that we saw in this study, and the rates of esophageal candidiasis on steroids were low and typically asymptomatic. Although, as Dr. Polydoroides points out, it can be easy to miss, so perhaps the pathologists at these centers were not looking closely for it. So again, important to mention when sending up pathology that when our patients are on corticosteroids. This important study led to an editorial in CGH where they concluded that maintenance therapy will be the standard of treatment in EoE. And they put this as no maintain, no gain. And so what about our patients who stay on treatment? We know now that if we take them off steroids, they are likely to relapse. But what about if they stay on steroids? And at what dose is the second question. The same Swiss registry did a long-term maintenance steroid trial where they reduced the dose to 0.25 BID after they had a clinical response, which was typically after 2 to 4 weeks. And they saw that on maintenance therapy, just under a third would remain in clinical remission with a median follow-up of 5 years. But adherence was a huge issue, and only 40% of patients were actually taking their steroids at visits. They did find, however, that 2/3 of them had a histologic relapse while on maintenance steroid therapy. And this somewhat closely correlates to the clinical non-response. There was no difference between relapse rate in the high dose, the people who stayed on the higher dose of steroid, the induction of budesonide 1 BID, or the people on the low maintenance dose. And they have median follow-up for that of 2.2 years. We do know that histological response relapse occurs earlier with the low dose steroid therapy. As you see here, the blue line is the low dose in the Kaplan-Meier, and those patients are relapsing sooner than those on the higher dose. And in both groups, there was a decreased need for endoscopic food removal due to food impaction. And so to briefly talk about an important studies that have come out in the last couple of years, about 2 years ago, a group in Cincinnati Children's Hospital looked at 150 EoE patients, both children and adults, and used a unique transcriptomic diagnostic panel to really look at their EoE transcriptome and try and understand the molecular targets. And they nicely discovered that there are 3 different pathologic subtypes of EoE. Here we see the clustering of groups on the principal component analysis. Type 1 is this mild subtype with some atopy. They're steroid sensitive and they have a normal appearing esophagus. So this is really the mildest group, the best group to be in. Type 2 is a much more inflammatory phenotype with high expression of inflammatory cytokines, typically onset in the pediatric age group. And then type 3 is really the most fibrotic, sort of more likely to have a narrow caliber esophagus and the most severe on endoscopy and less likely to be atopic. And these were more adults. And so here are some visual descriptions of what I've just described. Here on the right, you see the genes expressed, the 96 genes from the panel. And you know that in type 1 versus type 2 versus type 3, the genetic profile looks completely different. So we're starting to understand that EoE is not a single diagnosis, but instead can be broken down into different subtypes. The subtypes didn't differ by their peak eosinophil level, the sex, race of the patient, or the time since diagnosis, but adults were more likely to have a fibrostenotic phenotype. And so what does the future hold? We know that omalizumab, which is anti-IgE, and Remicade are ineffective, and that's probably because of the multifactorial nature of the disease, which allows the persistence of inflammation even after blocking single molecules. Some recent trials of anti-IL-4 receptor, anti-IL-5 receptor, and anti-IL-13 have shown some good promising results in terms of symptoms and histologic remission, especially in that EoE type 2 group. That's the most inflamed group and probably going to be the easiest to treat. You can also treat that group with therapies against eotaxins, which are the cells shown here, or the chemoattractant receptors on the type 2 immune cell. And what can we offer our patients here at Mount Sinai? Dr. Chehade has several studies that are enrolling adult patients. So if anyone has adult patients that are not responding to certain treatments, it will be worthwhile discussing with her whether your patient can enroll in either the anti-IL-4 or 5 receptor or the Siglec-8 antibody trial, which is an antibody on eos and mast cell surfaces. And so I'm going to stop there. and ask the final round of questions. I think to me, one of the most interesting pieces of this is the phenotypes that we have now discovered, or the subtypes of EoE. And so I guess this is a question for Dr. Chehade. Do you think that there are 3 separate phenotypes and you're destined to be in one of those based on your genetic makeup and your environmental exposures? Or do you think that there's progression over time where children who aren't treated inadequately are progressing to that fibrostenotic profile as an adult?
So, Stephanie, the paper by Shoda and colleagues is really interesting, and it's still too early to tell. I think it's nice that they're starting to show us these different phenotypes. However, if you look at the study more carefully, it is a cross-sectional study. So what we really need is to look longitudinally what happens, because some of the findings they're getting here is due to that progression of disease as opposed to a totally different phenotype. So we have to tease that out before we know what's the real difference between those patients. And so I'm positive, because I know there are current studies now taking this further and looking into it. I think the studies that will be offshoots from all these responses to biologics will give us a lot of answers, because when we're targeting a T helper type 2 allergic pathway with one of these biologics, and we see responders versus non-responders. So now all of these transcriptomic assays are being done, and further analysis will tell us really how many phenotypes, who are the non-responders to an allergic pathway. Is this now the patient who doesn't have that much of the allergic phenotype or more of the fibrotic phenotype, etc. So still early to tell, but definitely something to follow, so we know more how to target treatment eventually.
I think it's an exciting time. You can possibly, there will be personalized medicine for EoE, which I think is amazing. And final question before I'm going to turn to the audience for any questions that they might have. Dr. Cohen, what is your end goal? Are you trying to take these patients to both histologic, clinical, and endoscopic remission? Because even in Crohn's, we're not treating to histologic remission yet. So do you think that that leaving these patients with some EOs might progress to strictures, or what is your treatment goal for them?
Yeah, well, I think that's one of the $64 questions, is what should be our endpoint, either clinically or in clinical trials. And I think more and more, I think everyone now is leaning towards using the endpoint of both clinical and histologic resolution. And you could also throw in endoscopic resolution as well. So I think our endpoint is becoming more aggressive, and one can make analogy to the historical trend in treating IBD as well. So I think our endpoint today really must be histologic resolution along with clinical improvement.
Yeah, I agree. I think that is the way that we're going. And so just to leave a little bit of time for questions from anyone in the audience, I'll summarize here. EoE is an allergic disorder. We know that the prevalence is on the rise, and not just because of increased recognition. This is a picture from a website that Dr. Cohen sent me, which is ceoe.com, where they're trying to promote recognition of the disease. Made me feel slightly better about missing the diagnosis for many, many years. And so PPIs, as we now know, are no longer required for the diagnosis of EoE. They're now part of the first-line therapy and have minimal side effects. We also know that topical corticosteroids are very well tolerated, with some low rates of candidiasis, but otherwise well tolerated, but difficult to keep patients in histologic remission, as many of them are relapsing while on the steroids. Also difficult with adherence and cost. Dietary therapy, another reasonable first-line option, but adherence is problematic. And so consider the 2-6 step-up diet, which may be easier to do. And then the AGA guidelines in 2020 suggested that it is reasonable to do an EGD to assess disease activity after a change in therapy. But how often to scope thereafter, we don't know. And finally, as our panelists have discussed, there are emerging biologics which are targeting the type 2 immune response, which are likely going to revolutionize the way that we treat EoE. And we may be left with EoE as the new IBD, with a panoply of biologics to choose from someday. And so with that, I'd like to say a huge thank you to all my 4 panelists and to everyone who helped me create this presentation, Dr. Sands, Dr. Nagula, our chief Zoe and Yakira, and Dr. Rubin, as well as to my mom and dad, and to Dave, my patient and fiance. So thank you everyone for your attention. And we have if anyone wants to ask a couple of questions, we have maybe 1 or 2 minutes.
Steph, can I ask one?
Of course.
That was amazing presentation of a really common disease, and you hit on all the points that we all deal with every day. I loved seeing your fiance in the presentation. That was like a total highlight. My question is for Myrna. So can you tell us a little bit more about your studies and when we would actually talk to you about patients? Like, should we be treating them with PPIs or topical steroids first and then talking to you, or should we talk to you at the onset?
Good question. I still think that PPI is a good first-line option for many of these patients. As Stephanie showed, the response rate is 50%. So it's not small compared to all the other treatments that we are able to offer. But if a patient is not PPI responsive, that's when I would start the discussion. So I would not wait till they are also not responding to a topical steroid or did not want a topical, or not respond to a topical steroid, and that's because some of the biologics we're using now are really targeting the allergic type 2 response. So for example, if you have an EoE patient that has a bad allergic rhinitis on a topical steroid and or asthma also on a topical steroid, inhaled steroid on and off, this might be a good candidate for those clinical trials where now it's kind of a one-stop shop, if you will, where they could treat their EoE and also treat their other atopic comorbidities. So this is when I would consider that patient unless they just want a steroid. Now, the other thing, it sometimes comes down to the practical things that insurance doesn't approve the steroid. They get a side effect from steroid. It's hard for them to continue the steroids. Then the practical benefits of these trials is that there are subcutaneous injections that they could do at home once a week or every other week, and for one of the trials once a month. And so so that also might be an attractive option for the patient. So I would say anytime there's no response to PPI, that is, if anyone shoots me an email, we'll take care of these patients. Now, because these are all clinical trials, so they do require us to have dysphagia as one of the symptoms, because that's the clinical PRO that they're scoring and following up. But that's not too hard sometimes when you have an adult patient, because even if they tell you they don't have dysphagia and it's always refractory heartburn, if you dig deep, you'll find some behavioral feeding modifications that will make the dysphagia surface. So dysphagia, no response to PPI, we have several biologics, as Stephanie mentioned.
Perfect.
Great, thank you.
Nice picture, Steph, at the end here too.
Oh yeah, Central Park. Any other questions? Anyone else in the audience want to ask anything before we wrap up? Okay. I think it's been an amazing discussion. Thank you again so much to my panelists. I really appreciate you taking the time to give us such insight into EoE, and everyone enjoy the rest of your day and the weekend.